Considerations for optimizing CRT in NSCLC. Patient cases. The views and opinions expressed in this video are those of the individual oncology specialists and do not represent the views or opinions of AstraZeneca. This video contains anecdotal information gathered from a discussion with oncology specialists based on their opinions and experiences. Recommendations are general and may vary with patients. At the time of this filming, the healthcare professionals featured were in the roles and at the institutions indicated. Here, we'll present a team discussion of 3 cases of patients diagnosed with NSCLC, one with T3N2, one with T3N3, and one with EGFR mutated T4N3.
Hello, I'm Dr. Janakiraman Subramanian. Welcome to our video series on the changing landscape of unresectable stage 3 non-small cell lung cancer. In this video, we'll be discussing 3 cases of patients with unresectable stage 3 non-small cell lung cancer.
My name is Bobby Mahajan, and I'm an interventional pulmonologist.
I'm Stephen Sean. I'm a radiation oncologist.
Hi, I'm Dr. Boris Sepeshi. I'm a thoracic surgeon.
Here is case number 1, a patient with stage 3A T3N2 NSCLC.
Let's look at our first patient here. So this is Alan, who presented to his primary care with a prolonged and productive cough. He's 67 years old and a former tobacco smoker with a 40-pack year smoking history. And this cough has been of prolonged duration, and it has not improved despite taking some over-the-counter medication. He does have some additional medical comorbidities like hypertension and asthma, but good performance status ECOG-PS at 1. And he had an initial chest X-ray done, which shows single mass in the lung, and that's concerning, obviously, for malignancy. And so his primary care refers him to a pulmonologist for further evaluation. So Bobby, when you see a patient like this, how does the referral pattern work? How do these patients get referred to you?
The referral patterns are multiple. Sometimes we see nodules that are incidentally found, for example, in a patient who might just have a cough or comes to the ER and they get a chest CT that shows a lung nodule. Other ways we see are patients who have symptoms associated with possibly larger masses, or through lung cancer screening, they are sent to multiple different physicians before they get typically to the right physician or to the multidisciplinary meeting.
That is a challenge for our patients. So this patient, when he's seen by his pulmonologist, gets a PET CT and also has PFTs and a bronchoscopy done as well. The CT scan identified right lower lobe lung mass measuring 4 centimeters and invading the chest wall. And on the PET CT, not just the primary tumor, which was FDG avid, also the hilar and mediastinal lymph nodes had increased FDG uptake, concerning for cancer. So PFTs are reasonably good, DLCO at 70%, FEV1 at 70%. Bronchoscopy was done with EBUS, and he has both the tumor as well as the lymph nodes are positive for malignancy. And at this point, this patient was referred to see a medical oncologist. Are there any tests you would get at this point, Bobby, for this patient?
Even though the easiest way to approach this might be to just do a needle biopsy of the nodule, it provides us with a diagnosis, but it does not provide us with all the data we need. We really need to be able to stage these patients, see if there's N2 disease or N1 disease, if it's single station or multi-station. We would want to be able to send this over to our medical oncologist and a radiation oncologist. And at that point, then talk about to our navigators about getting a PET CT, a brain MRI, so that again, when they hit the medical oncologist's office, all of that data is already obtained.
Well, I definitely think that the biomarker testing should be done essentially immediately at the time of diagnosis. The biological behavior over here is aggressive. I would certainly not recommend an upfront operation in this situation. I think this patient should definitely be treated upfront with either systemic therapy or potentially just go the pathway of concomitant chemoradiation. But this is where the biomarkers, they must be done in order to make this decision, in terms of is this EGFR or ALK positive and what is the PD-L1 status.
So Bobby, what are you looking for? When you have a really tiny sample in the initial biopsy or you think it may not be adequate for molecular testing, what do you do to mitigate that?
Well, I think that in a lot of ways, we have to use all the resources available to our disposal. Really, it is important to take your time, biopsy at least 2 malignant nodes if present, so that oncologists and the pathologist especially can choose between different cell blocks on which sample should be sent for NGS to get the best chance of actually getting a full panel back.
Boris, in your opinion, do you think this patient is resectable or borderline resectable? And overall, how do you manage patients with stage 3 and 2 disease?
I think that I would classify this patient as a borderline resectable because he has a primary tumor that's abutting at least the parietal pleura, and certainly it seems that the nodal disease is already spreading from N1 station to multi-station N2 disease. From anatomical standpoint, I think that this operative field sort of encompasses the entire visible disease on the CT scan, and therefore I would believe that in my hands, this is still potentially a resectable disease. However, with the caveat of the way this disease is acting biologically, and this is why I would like to know the biomarkers prior to this, as well as I would discuss this patient in multidisciplinary setting for different neoadjuvant or other treatment options, or options for non-surgical options as well for concomitant chemoradiation.
I want to also echo Dr. Sepeshi's comments and emphasize the importance of reflexly getting biomarkers. I also want to discuss a potential situation of a patient like this receiving neoadjuvant therapy. I would argue for involving the radiation oncologist up front before making that determination, because it's possible, like in this case, that a radiation treatment volume could be developed safely that did not require neoadjuvant therapy. I want to emphasize that even in tumors that, let's say, do not respond to neoadjuvant therapy, or even, let's say, subtly progress on neoadjuvant therapy, that does not necessarily mean that it would not respond to concurrent chemoradiation. That's a great pearl of wisdom I learned from the great Wally Curran, actually. Just because someone doesn't respond to chemotherapy doesn't mean that they won't respond to chemoradiation. But my preference is that radiation be involved very early on and before decisions are made regarding neoadjuvant therapy.
In summary, this stage 3A patient was deemed borderline resectable. MDT communication was crucial in formulating the treatment plan. Understanding this patient's biomarkers was an important part of appropriate treatment planning. This is case number 2, a patient with unresectable stage 3C T3N3 NSCLC.
So here we have our second patient who's a former tobacco smoker presenting with cough and diagnosed with a lung mass or a lung opacity on the right side on her chest x-ray. Good performance status. So she has a CT scan which shows 5.2 centimeter right middle lobe mass, and lesion or the tumor is FDG avid on the PET scan. And then she has a CT-guided biopsy that shows that this is a non-small cell lung carcinoma. And they also get a MRI of the brain done, and she has a tumor board discussion on this case as well. So looking at this particular case, Stephen, what do you see as some of the challenging issues when you look at the PET scans?
So looking at this particular case, I think what jumps out at probably all of us here is the extent of disease. And whatever local therapy, I don't want to speak for surgery, but whatever local therapy is going to be used, this is a very large area that needs to be locally controlled. From a radiation standpoint, it is very important to have the best imaging possible so that we can make the radiation treatment fields as conformal and specific to the patient anatomy as possible. It's also very important for the patient to be optimized in terms of nutrition, in terms of side effect management, because there's going to be a very large amount of esophagus exposed to radiation. And also, I think, very close coordination with medical oncology, where concurrent chemotherapy would be administered. I also want to emphasize this case. When I look at the PET scan, we see supraclavicular nodes, or N3 nodal disease. I just want to emphasize, because I see this sometimes confused in some of my examinees, but this is stage 3 disease. It's not stage 4. And a patient like this, while treatment may be very challenging, these patients are very much candidates for curative intent chemoradiation, followed by appropriate consolidative therapy based upon their molecular profile. In this situation, surgery made a determination this was not appropriate for a resection with what we see here, bilateral mediastinal metastases, right supraclavicular nodal metastases, and a fairly locally advanced right middle lobe tumor.
So, Boris, what are the clinical characteristics that you look for in determining whether a patient is either technically resectable as well as whether they are medically operable?
Yeah, so this is actually that interesting case that as I look at it as a surgeon. So on one hand, middle lobe is the smallest of all lobes, has only 2 segments, contributes 10% to lung function. This tumor is already pretty much including the entire middle lobe. So from the pulmonary standpoint, removing the lobe probably would not be that morbid for the patient. But the deal breakers over here for me are certainly the contralateral disease and supraclavicular disease, because that's the disease distribution that is outside of the field. It's outside of the incision that I would make. I can certainly take out the node, but I cannot control all the disease. And therefore, I would not want to do a disservice to this patient, even though this patient was technically operable. I'm unable to achieve complete resection of all visible disease, and therefore I think this patient would be best served with my colleagues from radiation and medical oncology.
We have to look at all the collateral issues that could come not only before and after treatment. So I think that when we have everyone on the same page on a regular basis, looking at not only what are we going to do today, but what are we going to do 2-3 months from now, in this case, no appreciable disease as opposed to surgical cure.
So for a patient like this, at my institution, radiation oncology would be involved up front. Now, that being said, not every institution has a upfront multidisciplinary evaluation, but I would think that very shortly after finding that this is N3 nodal disease, let's say the patient's seen a surgeon, I would be surprised if a radiation oncologist wasn't involved at that point.
In summary, this patient has unresectable stage 3C NSCLC. Patients with unresectable stage 3 NSCLC can be candidates for curative intent CRT, followed by consolidation therapy. Radiation oncology should be involved early in determining the appropriate treatment plan. Here is case number 3, a patient with unresectable EGFR mutated stage 3C T4N3 NSCLC.
So we are here with our final case for this program. So we have Henry, who's a 68-year-old retired police officer, and who presents with cough and shortness of breath. And he is a former tobacco smoker, but quit long back. And he basically presents to his primary care. So we do know that he has lung cancer because he has a PET CT. There you can see a hypermetabolic mass with mediastinal adenopathy, has an EBUS, and the biopsy was positive for lung adenocarcinoma. No intracranial metastases is what we have. And he is highly motivated in getting a curative intent treatment. So knowing this particular case, Stephen, what would you recommend as his frontline treatment?
So again, I think in alignment with what we were discussing earlier, the importance of doing reflex biomarker testing. I would want to have that information before proceeding with treatment. So I'd want a surgical opinion. I'd want invasive staging to determine the lymph nodes that were positive. And I would also want just baseline information, MRI of the brain, full staging workup before proceeding.
So to you, Bobby, at what point would you consider biomarker testing for Henry?
So looking at this case, I would recommend biomarker testing immediately upon diagnosis and getting tissue.
As a medical oncologist, the first thing I'm looking is whether they have the biomarker testing done. So Stephen, when you're seeing a patient like this, when do you typically see the biomarker results becoming available to you?
If there's some kind of a delay, something that is unresectable, determined to be unresectable, whether or not there is a biomarker like EGFR or PD-L1 or ALK, the initial standard is still concurrent chemoradiation.
In your institution, who orders the testing?
So medical oncologists have been kind of in charge of that, but we are really right now trying to educate everyone, so surgical teams as well as pulmonologists. And again, we really try to involve navigators to help to make sure that this is done. I honestly think that it should be done reflexively by pathologists. I think that is the most efficient way of doing this.
In summary, this patient has unresectable stage 3 EGFRm NSCLC. All eligible patients should receive biomarker testing around the time of diagnosis. CRT is part of standard of care treatment in unresectable NSCLC.
So this brings us to the end of our discussion on patient cases with unresectable stage 3 non-small cell lung cancer. I believe they've helped highlight the importance of MDT communication and collaboration, as well as the increasing importance of biomarker testing for ensuring optimal clinical and treatment decisions in this setting.